Okay, so we
Okay.
So
Today
let
I
me
will.
say a few things before you start. So basically today we're going to, this is not a lecture, this is just a discussion on a very important topic. Very important situation we face on daily basis in ICU when we have a patient who has acute kidney injury or renal issues and also has hypotension. So we use fluid, we use inotropes, we use vasopressor, and sometimes there is a confusion or question. So just to clear off those things, we're going to talk to each other. I'm sure we are gain from each other experience and what the evidence-based medicine tells us to follow any protocol. So we'll discuss that issue. So before we do that, Dr. Zahid Beg, he will present some basic characteristics of different vasopressor available. So we'll start from that and then we go from there. Okay, Dr. Zahid, please go ahead.
Thank you very much, Dr. Wes. I welcome you all to our second session of critical care nephrology. And as Dr. Wes has pointed out, we are going to discuss vasopressors and inotropes today. A brief, you can say, a presentation. So vasopressors are the agents which induce vasoconstriction. Similarly, inotropes, as the name depicts, increase the cardiac contractility. Now we have inodilators. These agents have inotropic effects that also cause vasodilatation. So commonly used agent in Pakistan is epinephrine, also known as adrenaline, noradrenaline or norepinephrine, then dopamine and dopamine. These are the four commonly used available agents available in Pakistan. The other agents include vasopressin, milrinone, and levosimendan. The receptors are very important, and I'll give you a quick revision on these receptors. So alpha-1 receptors are present in the blood vessel walls, and their activation causes vasoconstriction. So the agents which cause this effect on alpha-1 receptors are known as vasopressors. Then are the beta-1 receptors. These are present in the heart, and they increase inotropy and chronotropy. And the agents we call this are known as inotropes. Then beta-2 receptors are present in the vessel wall. The activation of these receptors leads to vasodilatation. And as these agents also activate beta-1 receptors and beta-2, so these are known as inodilators. Then we have dopamine receptors. These receptors cause vasodilatation of renal, splanchnic, coronary, and cerebral vascular beds. And dopamine in low doses basically activates these receptors and cause this. And as the dose increases, the dopamine then acts on beta-1 receptor, causing chronotropy and inotropy, and finally on alpha-1 receptors, which leads to vasoconstriction. Then V1 receptors are for vasopressin, and these are on the vessel walls and cause vasoconstriction. And of course, vasopressin is also a vasopressor agent. Now, coming to the agents, this is basically a short summary of these agents. Adrenaline or epinephrine basically acts more on beta-1 receptors. So as beta-1 receptors we know are present in the heart, so it causes chronotropy. To lesser extent, it acts on alpha-1 and beta-2 receptors, but alpha-1 causes vasoconstriction and beta-2 causes vasodilatation. So these effects basically equate each other. So there may be some or no effect on vessels, but mainly it is on the heart. Uses include cardiac arrest, and we use adrenaline in cardiac arrest. Then anaphylaxis is another important indication of adrenaline. The problems we can see can cause lactic acidosis, low potassium, and low phosphate, etc. Noradrenaline acts mainly on alpha-1 receptors, so causes vasoconstriction, and to some extent on beta-1 as well. Its main use is in septic shock and vasodilatation due to neurogenic shock. In hypovolemic shock, when we replace the fluid and still there is space for a rise in blood pressure or we need an inotrope, then noradrenaline can be used for that as well. So the problems are reflex bradycardia and peripheral ischemia due to vasoconstriction. Dopamine has different effects in different doses. Less than 5 microgram, it acts on dopamine receptors. 5 to 10 beta receptor causing increase in basically cardiac contraction, and more than 10 it acts on the alpha receptors on which it causes vasoconstriction. The biggest problem is arrhythmias with dopamine, so it has basically decreased now. And it can be used as a second agent to noradrenaline for septic shock. Um, now, after that, the dobutamine, it is an inodilator. It acts mainly on beta-1 receptors. Beta-1 receptors are present in the heart, which increase inotropy and chronotropy, and beta-2 receptors lead to vasodilatation. So its main use is in cardiogenic shock and low cardiac output state. And it is used as an early goal-directed therapy in cardiac surgery as well. Now, the other agents, which includes vasopressin. Vasopressin, I have already pointed out, has V1 receptors on the vessel wall that leads to vasoconstriction, and it can be used as an add-on therapy after noradrenaline in septic shock. It has also been used in cardiac arrest it's now in the protocol of cardiac arrest basically. It can cause pulmonary hypertension, splanchnic ischemia, and thrombosis. Thrombosis because it increases the platelet aggregation as well. Milrinone phosphodiesterase inhibitor increases cyclic ANP by decreasing its degradation. That leads to increased calcium in the heart muscles and increased cardiac output. So it is an inodilator and it causes dilatation of the peripheral vessels. Its effect is almost similar to dobutamine, so used in low cardiac output states, cardiac surgery. Hypertension is the main problem. Levosimendan basically modulates troponin C as a result of which again calcium is increased in the cardiac muscle and that leads to increased contraction. It also activates vascular ATP dependent potassium channel leading to vasodilatation. So similar to dobutamine, it is used in low cardiac output states and it can cause tachycardia, low blood pressure, headache, and cannot be used in liver and renal diseases. So dobutamine, milrinone, levosimendan basically can increase the cardiac output, but as they also cause vasodilatation, so blood pressure in fact may decrease because of these. So we can't increase the blood pressure. If we have to increase the blood pressure, we need another agent in this. Finally, coming to the doses, I'll quickly go through this. You can see the figure of 5 in this. So adrenaline, noradrenaline, and levosimendan, it is 0.05 micrograms per kg per minute. Then in milrinone, it is 0.5 microgram per kg per minute, and dopamine and dobutamine have 5 micrograms per kg per minute. This is the starting dose. So we can then go up or down the dose depending on the patient's condition. Vasopressin is 0.04 units per minute. It's not units per kg, units per minute. So this is vasopressin, which has a different dosage. I'll just quickly go through this figure, just a revision basically, because this is very important in treatment. Sir? So this is for the treatment of the shock. If we see this, if you can see my arrow, this is the normal curve. So this is the normal curve, and in normal curve we see as we increase the preload, the cardiac output will increase. So if a patient is hypovolemic, we just need to increase this preload, we need to increase the volume and the cardiac output will increase. So this is, in this patient, which may be due to a cardiogenic shock, the curve had shifted towards the right side. So as we increase the volume, this cardiac output will increase. After some time, it will plateau up. So at this place, we need an inotrope which will shift the curve towards up and left. As the curve is shifted towards the left side and up, so add us. Am I audible? Am I audible?
Yeah, you're fine. You're fine.
Okay. So in cardiogenic shock, as we increase the volume and we reach a plateau, from here we can add an inotrope and that will shift the curve upwards and towards the left, and that will improve the cardiac output. So finally, thank you, I hope. have done the revision work, and now it would be taken over by Dr. Vasna.
Okay, thank you, Zahid. Very nice brief introduction of the vasopressor available. And then now we will talk how to apply them. And also, again, this is an academic session, so we will not go like, oh, this is my experience or works for me. All we need to talk about evidence-based medicine. So what the recent trial shows, what medication should be used in what situation. So basically, let's revise again the different receptors and the different vasopressors. So receptors, again, they are alpha receptors, which are mainly in blood vessels. And when the alpha receptors are stimulated, called peripheral vasoconstriction. And then we have a beta receptor, which are mainly in heart, beta 1 receptors, which are chronotropic and inotropic action. And then we have beta 2 receptors, which are basically peripheral vasodilators. And then we have vasopressin receptors, which are V1 receptor, which are predominantly in the blood vessel, cause vasoconstriction, and V2 predominantly in the renal tubules. And we have dopamine receptors, which are many places, including the kidneys and mesentery, and also in heart. So those are different receptors. And now there are different medication which are works on different receptors, and at a different concentration, the stimulated receptors are also different. So let's start about the effect on the kidney of different these medication and receptors. So let's talk about first most commonly used vasopressor, which are norepinephrine. Again, norepinephrine is much less disputed. This is a vasopressor which are used in most of the situation in shock, whether it's septic shock or it's cardiogenic shock. Levofet is the, or norepinephrine is the drug of choice to start with. And there's a reason behind that. It's basically is a alpha receptor agonist, is a very strong alpha receptor agonist, which cause peripheral vasoconstriction. That's why it causes the increased blood pressure. It also has effect beta 1 receptors, but not as strong as epinephrine, but it causes positive inotropic and also chronotropic effect, because it causes vasoconstriction and it causes increase the preload, and that causes reflux bradycardia. So it nullifies to some extent this effect of being positive chronotropic effect. As for the kidneys are concerned, it actually has receptors on afferent arterioles. So theoretically, it should cause some vasoconstriction at afferent arterioles, but practically shows that norepinephrine does not decrease renal perfusion even in shock when given norepinephrine. Probably its effect as a positive chronotropic and inotropic effect, it increases the cardiac output a little bit. That's why it does not decrease the renal perfusion when given in condition of shock. So that's why one of the reasons that norepinephrine is considered to be drug of choice, first choice in patient with the septic shock. Even in cardiogenic shock, it is preferred vasopressors. It's preferred over dopamine. And because studies have shown that outcome is better with the Levofet when compared with direct comparison with dopamine in cardiogenic shock. So again, in cardiogenic shock, norepinephrine is the medication preferred over dopamine. Actually, in dopamine, all the recent evidence shows that it has almost no role as a vasopressor, even as a cardiogenic shock or even is septic shock or any shock condition, except when patient has bradycardia. Otherwise, dopamine role is pretty much obsolete now. Again, please interrupt me right there. You don't want to hear full, long statement before you have any question. This is more like a discussion. So any question at any time, please interrupt me and ask question. You might have another opinion, which is fine. So I'd like to make it as a discussion. So any question up till this point, Levofet or norepinephrine as the first choice, and dopamine pretty much we should not be using except very few situations. Okay, back to Pakistan. Do we use dopamine a lot? Is that right, or we don't?
Yes, we use quite a bit of dopamine actually.
Okay. So in what situation you will use dopamine? Like
It's not actually situation specific actually. So वो हमारे जो सीना बसीना वाली knowledge वाला जो theory है ना. So if you go to any hospital, they know that somebody goes into shock state, they're going to put him on norepinephrine and they're going to put the dopamine. And then the three drugs that we normally use in combination, which is not like evidence based, it's just that that's what they've been taught in government hospitals and other places, is that a combination of norepinephrine along with dopamine and dobutamine is the way to go. That's what most of the people do, even in all the three big hospitals of Lahore. That's what I know.
Okay, good. So basically, that was the precise reason for discussion. Aha told me that sometime many doctors are not very clear what to use. So basically, recommendation and is not very confusing anymore. It's pretty clear now that what vasopressor we should use in what situation. So that's pretty clear now that dopamine is pretty much obsolete now for most of the situation, except when patient has bradycardia, you need to give that. So that's one thing. So second vasopressor, let's talk about again vasopressin. Vasopressin is obviously it's a different receptors. This is a different medication. It has mainly when we use for as vasopressor, it is vasopressor which is works on V1 receptor, which are vasoconstrictive. They do not have any cardiac receptor, or they do not work as a inotropic or chronotropic effect. As for the effect on the renal perfusion concern, actually it has some beneficial effect. It causes constriction of the efferent arterioles. So basically with that, it increases the GFR in patient who has in shock. So that's a very, very, very desirable beneficial effect in the patient who are shock and patient who have risk to develop acute kidney injury. So that's why the vasopressor is a very good medication in patient with shock. The one thing is that it's still not the first choice medication, although there are many trials which compare vasopressin and norepinephrine, and actually results show that vasopressin is not inferior to norepinephrine. Some small studies showed actually it's a better choice than norepinephrine. But again, at this point, first choice is again norepinephrine, not vasopressin. So when you start patient on norepinephrine, you go higher dose, like 15 microgram per minute or higher, 20, and then you go all the way 30. At that time, you see some unwanted side effects of norepinephrine, like tachycardia or some arrhythmias. So you would like to keep it from going that high dose. So one strategy is that when patient requires higher dose of norepinephrine, like more than 15 or 20 microgram per minute, you add norepinephrine. And there are very good studies shown that this is definitely beneficial. This actually improves the outcome and definitely decrease the unwanted effect on a patient, which you can see with high dose of norepinephrine, like tachycardia or arrhythmias. So that's one strategy. So let's talk about just shock. So in septic shock, first choice is norepinephrine. And so you start with that, go high, and if patient needing more than 15 or 20 microgram per minute, then if you can add norepinephrine, you should add that. Okay. Then if both are not enough, like your patient is already on norepinephrine and patient is also on vasopressin, but still blood pressure is still low, you need more pressure, then the third choice would be either replace norepinephrine with epinephrine, or add. Okay, so I would request talking at the moment, please mute yourself.
Just ensure the host you can actually mute everybody. You just go ahead and mute everybody.
Let me see that.
Just a moment.
I muted everybody. Avas, you may want to unmute yourself now, please.
Got it.
Okay.
Thank you. Okay, so norepinephrine, then add vasopressin, and still blood pressure is low. You either replace norepinephrine with epinephrine or just add epinephrine. Almost, you obviously you have to keep an eye on that patient's heart rate and any sign of arrhythmias in that case. But same time, we see situation very commonly when patient already on tachycardia, patient has AFib, rapid AFib, patient has arrhythmias. You don't want any pressor which has a positive chronotropic effect or inotropic effect at that time. So at that time, probably you want to stop using Levophed or norepinephrine or epinephrine. So commonly here in USA also, people go on directly to phenylephrine or neosinephrine, which is a pure alpha receptor agonist. And because it doesn't increase any heart rate or does not increase any chronotropic or inotropic factor, that is considered to be drug of choice in that situation. But the recent recommendations are that rather than using neosinephrine, using phenylephrine or neosinephrine, use vasopressin in that situation. Okay, so effect of phenylephrine on renal perfusion. So because it's an alpha agonist, it does affect on vasoconstriction of the afferent arterioles. So it can decrease the perfusion, renal perfusion in that situation, which you are not needed. So there are different trials. Some small trials show that it does not affect renal perfusion, but some trials show that it does decrease. I think more consensus is that it decreases renal perfusion and in the condition of shock. So this is not the preferred medication in that situation. So these are mainly three vasopressor you should be considering in almost all situations. One is norepinephrine, then vasopressin, and then epinephrine. In some situation, you can use phenylephrine, but most of the time, vasopressin is preferred drug in that choice. Again, dopamine is not a vasopressor of choice in most of situations now, unless patient has bradycardia and you need dopamine for that particular reason. So any question regarding vasopressor before we go to inotropes?
So, Avas, can I ask you a question?
Yeah, please unmute yourself and please.
So there's two major scenarios in which we are called to use inotropes and vasopressors. One is septic shock and the other is cardiogenic shock, and it's formifructis. So is there a difference in your approach? I'm sure you're going to talk about inotropes in a second, but is there a difference in your approach on how you open up with a choice of agent when it's predominantly somebody coming out of cardiac surgery or somebody who's in septic in cardiogenic shock versus somebody who's in straight up septic shock?
Very important question, practically very important. We deal with the situation every day. And we see a lot of patients with in cardiac surgery unit here in our hospital. So it depends on what situation is, why patient has hypotension after cardiac surgery. Some patients are on because of call it stunning after cardiac surgery. Those patients needs to have epinephrine, not epinephrine. Epinephrine, they also has, if cardiac index is a little bit low. So epinephrine is a very strong inotropic effect also. So in post-cardiac surgery, epinephrine is used very commonly. If blood pressure is low and if cardiac index is low, because cardiac index is very strong inotropic, as strong as dopamine or even milrinone. So, and also if blood pressure is low, this medication will improve the blood pressure, while the dopamine and milrinone will not increase. Actually, they can decrease your blood pressure. But otherwise, if patient has in any septic condition or the other condition, I don't know exactly, it's a vago, I think pelagic condition, which is very common after cardiac surgery. Those patients are basically have good cardiac index, but they have hypotension because of their, they have vasodilator effect from the increased nitric oxide production or some other reason. they have SVR is actually low, vagoplegic condition. In that condition, you can increase, can use actually vasopressin. We use vasopressin a lot in post-cardiac surgery. The reason being that AFib is a very common problem in post-cardiac surgery. One of the most common reason for delayed state in cardiac surgery. So in that case, you use vasopressin. So vasopressin is a very, very commonly used pressor in cardiac surgery. But if patient has a low cardiac index in the beginning, then epi is a better choice. But if patient continue to have low cardiac index, then you have to give a milrinone, but at the same time, you have to give some vasopressor also at the same time.
Thank you.
You're welcome.
So Avas, this is Omar. So I think I'm sure like, I think that we can keep some of the cases after you talk about inotropes, but maybe I think once you discuss, I think if you could also tell us if somebody walks in the hospital with cardiogenic shock because of congestive heart failure, right? So they are volume overloaded and now they are in congestive heart failure versus somebody comes out of the CT surgery after cabbage or something. So something happened intraoperatively, as you mentioned, cardiac stenting. I think those are kind of perceived different scenarios because one is more controlled and CT surgeons, they have their own, probably, they're more used to taking their patient to only one specific ICU. They work with one intensivist usually, but I think the other patient can go to any different ICU in the hospital, sometimes neuro ICU, sometimes, just plain medical ICU, depending where the bed is. So I see some variability in approach into those situations. So maybe I think once you discuss the inotropes, I think we can have a discussion on that as what would be the difference between the first versus second, because they're both cardiogenic shock, but how they get into cardiogenic shock was different.
Yeah, thank you. Yeah, we'll talk about that. Let me just briefly go over the other inotropes and then we can talk about open for discussion. So basically inotropes, we don't have too many, basically two. One is dopamine. Dopamine has stimulates beta-2 receptor, which are vasodilator effect, and also has beta-1 receptor, which is a positive, inotrope effect. So it is different from milrinone because it actually is a short acting relatively, and also it's not, you don't need to worry about any renal function to adjust the dose, but it has a effect or tachyphylaxis effect. So it affects, it goes down after a passage of time. That's why we don't see too many patients who go home or long-term dopamine drip anymore. Used to be. Now some patients need long-term inotropes drip and they go home on long-term milrinone drip, but not dopamine drip. The effect on blood pressure also is variable. If patient can improve his or her cardiac index with dopamine, then it can improve blood pressure a little bit. But if the predominant effect is on beta-2 receptors and vasodilator, then it can increase the blood pressure. It can cause hypotension. More commonly used inotropes is milrinone. Milrinone has more stronger vasodilator effect as compared to dopamine, and has also has inotrope effect in a different mechanism. The most important thing for nephrologists is to keep an eye on that this drug is renally excreted, and the dose need to be adjusted if patient's GFR is low. There's a nice, you can find everywhere that at what dose should be given, like a starting dose most of the time is 0.375 microgram per kg per minute, which cardiologists put like default every time. And every time I go see patients, GFR is very low, like 20 something, and patient is going the same dose of milrinone, which is very high for that particular patient because of low GFR. And that can cause a lot of problem. That can cause hypotension, which is most commonly. So this is the thing we need to be aware of. And this medication does not cause tachyphylaxis. So many patients we see who have cardiomyopathy, they go home on long term. I have a patient who is on milrinone drip for 2-3 years now. So that can be used and are being used on a long-term basis also. So another inotropes is basically epinephrine, which are used in cardiac surgery commonly. The reason cardiac surgery, because these patients are post-CABG patients. So their vessels are okay. They have like new tubes put in. So they're not too much worried about causing coronary ischemia, which can happen in a patient who's already in ischemia if you give epinephrine. So that's why Dr. Umar is talking about that. This scenario is different when patient is cardiac surgery or compared to other units. Okay, so let's go over questions regarding inotropes or vasopressors. So, Umar, you had some question, any particular scenario?
Yeah, I do. I do want to discuss something. I think this is so most commonly when we are asked to see a septic shock patient who is also in acute renal failure, right? So they are probably in the phase of ATN and they are oliguric. They're not; these patients are not making much urine, and you know, the teams keep giving fluid, you know, loading them a lot. So, and many of these patients have other comorbidities. Some may have underlying a mild degree of congestive heart failure. Some may have some liver disease. So a patient who has relatively weak heart came in with septic shock. And is also in acute renal failure and ATN, and then we keep giving them IV fluids. And I think there has been variability at what point do you start the vasopressors and or inotropes and or, you know, any of these medication. So what has been, you know, word on that, early versus late?
I mean, there is one concept we need to keep in mind. There's an organ perfusion pressure. So that applied to cerebral pressure, perfusion, renal perfusion, and also cardiac perfusion. So this patient is a septic shock. Okay, this patient has congestive heart failure to begin with, and already patient has risk to develop volume overload because of renal failure and because of cardiac condition. So in this patient, if you keep giving fluid, that will increase the venous congestion in this patient. So that will actually hurt the kidneys and increase the, exacerbate the renal injury on those patients. So in this patient, basically the very basic concept of patients preventing acute kidney injuries, keep the patient euvolemic, okay? And now there's a trend to start in every patient to start vasopressor early is basically one of the advantage of starting vasopressor early to prevent volume overload, which we're seeing that is a more problem than volume depletion nowadays, because we have learned a lot that volume, but I think we are going a bit too much on that. So in this particular situation where patient already has compromised EF and patient already has or can develop congestive heart failure quickly, we need to start vasopressor early rather than late.
So the question actually is, I'm just about to go back to what actually Dr. Umar was saying. So I understand from a cardiac surgery point of view that probably because of cardiac stunning, and there's not a problem with the vessel, so epinephrine ko abuse kar rahe hoge. But in terms of the scenario that he was saying that the patient is, you know, we get to see patients in the ICU, we receive a call, कि medical ICU mein patient hai and he's got congestive heart failure. So am I right in assuming that the first drug of choice would still be norepinephrine, number one? And number two, the thing that I want to ask is that considering that the patient has a low EF, so ये जो आप कह रहे थे कि number max out करना है, let's say 20 के बाद दूसरी inotrope add करनी है, because with a weak heart I would be worried कि ज़्यादा उसको tachycardia होगा तो उसमें भी problems होगी, although वो बाकी inotropes में भी होगी. Would you sort of want कि जी नहीं, अगर poor EF है तो मैं norepinephrine के साथ दूसरी कोई चीज add कर दूं पहले, but let's say 15 के ऊपर ही? Your comments on that?
Yeah, sure. In this situation, basically in cardiogenic shock, again, the dopamine is still out in this situation. We have seen that in cardiogenic shock, comparing norepinephrine and dopamine, dopamine cause increased mortality, and so dopamine is not the choice. So you will start with norepinephrine, and you think that patient has enough vasoconstriction, patient needs to increase the cardiac index. You can add dopamine to that patient. Okay, and you can add dopamine, yes, in that case, if you think that patient's cardiac index is low, but dopamine is not the choice. And blood pressure, if still low, then you should add vasopressin on that, because dopamine will not improve blood pressure a lot on this patient. Maybe if patient's cardiac index is low, you can add, but still my will be go to norepinephrine first, and the patient is septic shock, then I will add vasopressin to that. And if you think that patient's cardiac index need to be improved, so EF is low, then you can add dopamine to that and keep the dopamine away, even in this situation, unless patient is bradycardic for some reason.
And when do you think that dobutamine starts losing effect? You said that over time uska effect khatam hona shuru ho jati hai. It doesn't, it's not as effective as it was when you started. So 24 hours ke baad, 48 hours ke baad, you should consider ke ji nahi milrinone nahi honi chahiye thi, because dobutamine is easily available in Pakistan and in almost every city. Milrinone, I'm not too sure Lahore mein to hai, लेकिन it's just milrinone का नाम at least लाहौर में मेरे ख्याल है पिछले 5 साल में at least मैंने तभी सुनना शुरू हुआ. I don't think कि हर जगह उस तरह easily available होगी. So yeah.
It will take about 72 hours. I mean, you after that sometimes you need to increase the dose if its effect is not enough. I mean, not right away. I mean, it takes a few days before the effect starts going down. That's why it's easy to not to taper off after a few days. Sometimes some medication need to taper off. We don't taper off dopamine because it's tapered off by itself, because the effect is much lower now. But again, if wherever milrinone is available, milrinone should be the preferred medication, not dopamine, sorry.
So क्या पूछा जा सकता है बाकी लोगों से कि availability क्या है उनके पास Primacore की, जैसे अगर लाहौर से बाहर बाकी शहरों में?
गुजरांवाला में तो बिल्कुल नहीं है. अस्सलाम वालेकुम.
वालेकुम.
सर गुजरांवाला में तो नहीं मिल
तो
not available. We are only norepinephrine and dopamine, that's it.
That's okay. जो available है आपने उस पे ही काम करना है, तो that's fine. I mean, so go on Levofed, or most of the time you don't need dopamine. Levofed.
और वैसे भी milrinone वाला पेशेंट हम लाहौर भेज देते हैं. गुजरांवाला में तो फौरन लाहौर पेशेंट शिफ्ट होता है ना सर.
It can be arranged if it is available in Lahore. One can always arrange these things in the ICUs of places where it's not available, because Lahore and Gujranwala are quite near to each other.
Yes.
सर जिस तरह खुल के डॉक्टरी हो सकती है ना, गुजरांवाला नहीं है, सॉरी एक अलग टॉपिक है. लेकिन यह है कि लाहौर कुछ भी हो जाके पेशेंट को वो इतना ब्लेम करेंगे, लेकिन गुजरांवाला में हम जितनी मर्जी मेहनत कर लें, कोशिश कर लें, वो यही कहेंगे कि लाहौर ला जाते तो शायद बच जाता.
Okay. So basically, again, things are pretty simple. Levofed. Let's talk about different scenario again. Septic shock, Levofed, and then vasopressin. Add to that if available. If patient has tachycardia or arrhythmias, you're worried about giving norepinephrine. You don't want to give and start with or continue with vasopressin. And if that patient vasopressin not enough, patient still has arrhythmias. In that case, you can add phenylephrine or norepinephrine. So this patient would have 2 pressors without any effect on chronotropic effect. But again, otherwise, phenylephrine has no role in the beginning as first or second or third choice.
Sorry, just to sort of butt in. एक चीज मुझे सर पूछनी थी कि considering that norepinephrine, then moving on to dobutamine. So in this scenario, epinephrine का किधर कब किस time पे, when do you think, apart from cardiac stunning, do you think epinephrine on would there be any scenario जिसके अंदर second choice after norepinephrine मुझे epinephrine साथ लगानी पड़े, या dobutamine and milrinone, it's more or less the same thing?
I mean, one scenario, if you can monitor patient has a low cardiac index, and patient has needs some pressure. I mean, epinephrine is a good choice because epinephrine is a very strong inotrope and also strong as a vasopressor. But again, the comfort level has to be seen that some people don't feel comfortable starting epinephrine drip because it can cause frequent arrhythmias. Compared to that, dopamine does not cause that much arrhythmias. And if you have a combination like vasopressin and dopamine, that also a good combination. But again, we use epinephrine quite frequently. And actually, my own experience, I learned my experience from looking at patient in cardiac surgery. They use actually very high dose of epinephrine. So we learned that it's not that bad, it's not that dangerous to use, and it's quite safe to use epinephrine. So you have a patient who has low cardiac index and patient has on septic shock, and start with, again, I would start with norepinephrine. And if you worry about cardiac index is low, you can switch to, and blood pressure is still low, and you think by improving cardiac index, blood pressure might go better, you can switch from an epinephrine to epinephrine while keeping a vasopressin at the same time, or not. But again, yes, please go ahead.
No, Vas, I was just thinking like another scenario, क्योंकि I think discussion जो है ना वो एक तो ये है कि what do we see sometimes, you know, आप जैसे बता रहे हैं कि आपके hospital center में cardiac surgery बड़ी active है. I'm sure you see वो LVAD के patients भी और वो सारे devices के साथ भी. I think वो उनकी वो completely different type of population है. तो I think मैंने एक comment जो सवाल किया था वो water के बारे में, क्योंकि इसलिए आता है कि because of the early goal-directed therapy for the septic shock, a lot of time before patient is sent up, the patient is given 2-3 liters of fluid already. So my question was really kind of, you know, कि जो जिसका weak heart है उसको आप जरा ध्यान से fluid दें, लेकिन बाकी सब लोगों को पानी की मतलब fluid की जरूरत होती है शुरू से ही. So I think sometimes we have to differentiate at what point you need to stop and, you know, you need to switch gear and go to the other therapy. I think एक बड़ा थीम जो आज की डिस्कशन से जो मुझे बड़ा स्ट्राइकिंग वो लग रहा है वो है कि एज यू मेंशन कि जो एल्गोरिथम है इसका यूज ऑफ वेसोप्रेसर्स इन वेरियस सिचुएशंस, इट्स इजी एंड इट्स स्ट्रीमलाइंड. लेकिन जो लोकल हमारे वहाँ पे फैक्टर्स हैं जिसमें एक अवेलेबिलिटी का इशू है पाकिस्तान में, दूसरा इशू है सीना बसीना. जैसे उन्होंने बोला, अरसलान ने बोला कि भाई वो सीना बसीना नॉलेज चलता आ रहा है. तो डोपामीन जो है ना वो बड़ी अभी भी मेरा ख्याल है कि क्या डोपामीन is this the most commonly used pressor right now? I think I see some nod, 1 or 2 कि नहीं. तो या मतलब आप जब से कॉम्बिनेशन में जाते हैं तो क्योंकि डोपामीन आप कोई नहीं यूज करता यहाँ पे, तो एक ये हमने पॉइंट निकाल मतलब मैंने नोटिस किया है कि this is the gap. If we can cover this gap after this discussion today, maybe we can issue like a memo or something.
Sorry Dr. Umar, मैं disturb कर रहा हूँ. I'm Muteen Akram here. Actually the dopamine is using in that of the in hypertension is considered as a renal dose, in a renal dose of dopamine. The probably it is supposed to having a vasodilator effect in the kidneys. Probably it will increase the perfusion of the kidneys. So when we entered in the ICU and the medical officer in the ICU mentioned that this patient is in a hypertension, we started with the norepinephrine and the dopamine in the renal dose. Specified, he mentioned that the dopamine in the renal dose.
Renal dose.
So
yes,
that is the main problem.
Okay, can you comment on that?
Yes.
This is Wes. I mean, I did my fellowship almost 25 years ago. At that time, when somebody mentioned that renal dose dopamine, I was told that this was 30 years ago. People used to use reason to use dopamine. So you can imagine that it's like a 30, 40 years old thing. I mean, nobody
Still.
So you should not be. I mean, you should condemn that. I mean, I know more like
oh yes, sorry.
In this surgery unit, we used to see until 15. Last time I saw somebody talking about was a surgeon about 15 years ago. That because of renal dose dopamine. So there's no such thing. There's no study shown that it has any benefits. So you should discourage people who use dopamine as so-called renal dose dopamine to increase the renal perfusion on that.
सर हमारे
So
जाने से
that's
पहले स्टार्ट हो गई होती है ना
हाँ जी नहीं आप
हमारे
सही
जाने
कह रहे हैं. I think that's the comment I made कि क्या हम I think can we take this discussion today? I think all of us are talking. You know देखें पाकिस्तान में लोग रात 10 बजे बैठ के मतलब जागे हुए हैं and then you know बात कर रहे हैं सुन रहे हैं. I think what I was thinking is कि क्या this is a fact. I think मुझे पता है डॉक्टर तारीब नोमान ने भी अभी ज्वाइन किया. I mean he's very good in हमारी वो उनकी एडिटोरियल एबिलिटीज बड़ी जबरदस्त हैं. हमारे पास और कुछ लोग हैं जो they can you know write like some sort of one pager summary algorithm कि भाई this is the preferred जो आपका जो है ना step 1 step 2 step 3 और these are the do's and these are the don'ts इसमें ICU और vasopressor में क्या ऐसा हम कर सकते हैं. I think and then that can be circulated. I think अब तो लोग वो WhatsApp में भी इतने ग्रुप बने हैं मतलब this can be published too. वहाँ पे भाई local practice versus evidence based medicine में difference है. So, you know, you start a change somewhere. I think if this is identified, जैसे डॉक्टर मतीन अकरम ने बोला ना ये renal dose dopamine, it's such a reality. मुझे कुछ अर्सा पहले की बात है कि पाकिस्तान से फोन आया इस तरह मैं ICU के फिजिशियन से बात कर रहा था हमारे एक रिलेटिव के सिलसिले में and the same thing कि भाई हमने renal dose dopamine start कर दिया और कुछ भी नहीं किया, fluids भी नहीं दिए, without any fluids, without any levofed या norepinephrine. पेशेंट को एंटीबायोटिक्स दे दिए हैं और रीनल डोज डोपामीन स्टार्ट कर दिया एंड देन दे वर कंसल्टिंग विद मी कि भाई अब इस पेशेंट का क्रिएटिनिन वर्स से वर्स होता जा रहा है. तो आई थिंक यू नो मेरा एक मतलब मैं आई एम जस्ट थिंकिंग लाउड कि भाई कैन वी कन्वर्ट ऑल ऑफ दिस डिस्कशन इनटू ए पॉजिटिव एक्शन जो कि हम स्प्रेड कर दें. पाकिस्तान में देखें इतने सारे हॉस्पिटल्स हैं, इतने ज्यादा वो मतलब नेफ्रोलॉजी के भी यूनिट्स हैं, ICU के भी यूनिट्स हैं. I think this is something if this is a gap with which if group identifies कि एक ये practice है जो चलती आ रही है सीना बसीना knowledge से तो क्या can we do something to change it?
So एक और जो important thing है, I mean I don't know पाकिस्तान में available है कि नहीं ये drug phenoldopam. I mean is it available in phenoldopam in Pakistan? Probably not. Phenoldopam is a medication which was created basically, you know, when we talk about renal dose dopamine, and the concept is that low dose dopamine, it stimulates dopamine receptors, which are vasodilator receptors, right? It causes vasodilation of the renal perfusion and some mesenteric blood vessel. So phenoldopam, the drug was made. This drug stimulates only dopamine receptors. So that's why it caused the vasodilation. It was produced as an antihypertensive emergency medication. And we use a lot in after 3-4 years, still available as medication for hypertensive emergencies. So when this drug was being started or we started use, there was a big enthusiasm that it will solve many of our problems. It will solve problem same as increased renal perfusion in patient with cardiogenic patient or patient with the contrast-induced nephropathy when there's a renal perfusion is constricted. But again, this medication also proved to be of no use in that particular respect. So still available, we use very rarely now as antihypertensive medication. So there is absolutely no use of dopamine as renal dose dopamine for renal perfusion or increased renal perfusion. Okay.
Sorry,
one comment I just want to make about that the question which Dr. Umar was asking regarding that in the septic shock management after fluids, when you want to start the vasopressor. Because now in the last few years, the trend has been towards the less of the bolus. As the surviving sepsis guidelines you came to the, in 2016, everybody was giving that 30 ml per kg bolus. So what was happening that in the first day, the patient was getting a fluid about 6 to 8 liters. And the next day we had to resuscitate this patient. Patient was already having total cumulative fluid overload. So what the people now are suggesting that you should localize that, is there any associated vasoplasia with it? The best thing to look at the vasoplasia is to look at the diastolic blood pressure. If you have a low diastolic blood pressure, like 40, 45, and your systolic is like 90. So that patient have a little bit of fluid bolus, not the 30 ml kg, require an early vasopressor like levofed. So that will be a much more logical treatment for this patient, just to continue pushing the fluids for this patient, because the fluid is in the septic shock patient is already there. It is only in the unstressed compartment of the blood volume that it just you have to mobilize from the unstressed compartment, because he's vasodilated, he's SVR. You have to mobilize his fluid from the peripheral compartment into the central compartment. The other thing is that milrinone is available in PKLI, but we don't have much experience. We use little, but usually after, as you suggested, Levophed, 0.5, we use weight-based doses of Levophed in Pakistan. 0.5, when we go to 0.5 kg per minute, then the second drug vasopressin comes, and then the epi comes. Thank you.
I think his 0.5 is also a bit on the high side. I would start with lower than that.
Mm-hmm.
Okay, again, that's very good comment from Dr. Al Manzoor, because there you have to see whatever available you have, how you can assess that, how much patient needs fluid or not. So basically looking at diastolic blood pressure, also one way to check whether the patient has increased vasodilation or not, because diastolic blood pressure depends upon your peripheral vasodilation. So if patient has low diastolic blood pressure, probably you need to fill up the tank with the fluid, and also to constrict the blood vessel by use early vasopressin for that, because those blood vessels are dilated because of sepsis. So you don't have to waste.
एक छोटी सी मैंने सर बीच में एक क्वेरी एक्चुअली थी, मे बी शायद डायरेक्टली वेसोप्रेसिन वाला से रिलेटेड तो नहीं है. सो वी सी अ लॉट ऑफ पेशेंट्स इन द आईसीयू. बाय द टाइम वी रीच द पेशेंट, so the patient was hypotensive, came in with probably cardiogenic shock. तो होता ये कि the patient is already in AT and is not making a lot of urine, and they've already filled the patient up with so much fluid at that point. वो fluid से भर चुके होते हैं उस टाइम पे. So उस टाइम पे एक बड़ा हमारे लिए conundrum एक ये होता है, दो सिनारियो होते हैं. या तो ये हो रहा होता है कि एक तरफ से fluid जा रहा होता है, साथ दूसरी साइड से Lasix जा रहा होता है, जो कि I mean this happens. दूसरा conundrum ये है कि अब आपने उसको fill up तो कर दिया है. अब लेकिन ये है कि when would you start saying कि जी हाँ जी अब Lasix देने का टाइम आ गया है, अब देख लेते हैं, या फिर आप यही कहते हैं कि जी नहीं मैं वेसोकंस्ट्रिक्शन कर लेता हूँ, खुद ही जब आर्टीरियल फ्लो बेहतर हो जाएगा या वीनस फ्लो टू द किडनी इज बेटर, you would do that. But the question actually है कि is it all based on clinical कि जी chest में जब when you start hearing crackles only then you would give Lasix, or otherwise you would just wait it out? Let's say the chest is clear and the patient isn't making much urine. So what would that scenario be? The दो scenario आपके आगे पेश किए हैं.
एक scenario पहला जो है उसमें ये है कि patient tanks are full, अब you already given enough fluid, but patient otherwise lungs are clear, okay? So patient is not making urine. So I will not give Lasix just to see urine, okay? There's no reason to do that. You already just filled up, now you wait for that because patient has ATN and will have some time to recover. But other situation when patient has given a lot of fluid, patient already have congestive heart failure, patient has pulmonary congestion, at that time there's definitely a time to give Lasix. So that's what I would do.
आहद ये मसला ना जो आपने बताया, ये असल में ना ऐसा नहीं सोचना कि सिर्फ पाकिस्तान में देखा जाता है. सो अब अवैस इफ यू अलाउ मी कि मैं ना अपना पर्सनल एक्सपीरियंस शेयर करूंगा जो कि NF1 है, लेकिन हमारे पास ना 4 ICU हैं. एक हार्ट एंड वैस्कुलर ICU है, एक सर्जिकल ICU SICU, एक न्यूरोसर्जिकल ICU और एक है रेगुलर मेडिकल ICU. तो स्टाफिंग जैसे मेडिकल ICU में रेजिडेंट्स हैं जो कि हर महीने नया रेजिडेंट होता है, SICU में भी ऐसे ही है, लेकिन हार्ट एंड वैस्कुलर में उनके पास नर्स प्रैक्टिशनर्स और PAs हैं, तो वो उनका बड़ा ना बिल्कुल सेम उनके हर चीज के प्रोटोकॉल होते हैं. सो HV ICU में मरीज जो है ना, एवरी पेशेंट इज परसीव्ड एज फ्लूइड ओवरलोडेड. तो वो अगर पेशेंट कोई एयर से एक ड्रॉप ऑफ वाटर भी जो है ना वो एब्जॉर्ब कर ले तो वो दे वांट टू टेक इट आउट. SICU में ये है कि एवरीबॉडी इज ड्राई लाइक अ बोन, लेकिन वो मिचेल एंड मैन की तरह उनके वो नजर आएंगे आपको SICU के मरीज, लेकिन वो सर्जन यही कहेंगे कि यार ये मरीज बिल्कुल ड्राई है. ठीक है. जो MICU है उसमें डिपेंड्स ऑन के आप साल के किस, अगर तो आप जनवरी फरवरी के बाद हैं जब जरा रेजिडेंट्स थोड़े से समझदार हो गए हैं, तो उनको थोड़ा सा अंदाजा होता है, लेकिन मिक्यू में हिट और मिस होता है। कभी उनको पता होता है कि वॉल्यूम, वो कहते हैं कि कभी किसी को वो ड्राई बना देते हैं, किसी को वेट बना देते हैं। न्यूरोसर्ज वालों को वो कहते हैं भाई हमें तो कख पता नहीं, ये हमने कार्डियोलॉजी को भी बुला लिया, नेफ्रोलॉजी को बुला लिया, वो आपस में बात करें कि क्या करना है। So ये जो बैटल है, this I think it is still not settled or sorted out. लेकिन we get called into the situation जैसे एक patient multiple myeloma का patient cast nephropathy के साथ आया है, right? So the second question, I think we should probably have some discussion on use of diuretics, क्योंकि historically the diuretics की जो guidelines वो थोड़ा change किए हैं over the years, right? So there was a time, and also the practice varies. So myeloma का patient जो cast nephropathy में है, once you fill their tank, you want to diurese them. Whether पहले लोग mannitol भी suggest करते थे, आप loop diuretics भी use करते हैं. लेकिन I think आहत का question बड़ा valid है कि भाई at what point in a renal failure patient do you add diuretics? I think you have answered very eloquently. This is what we do. So this is based on the volume status. But sometimes the assessment of volume status is an issue, because hepatorenal syndrome के अंदर volume status की assessment थोड़ी different हो जाती है than the regular cellulitis related septic shock patient के साथ. So I think ये एक, maybe I think we can have open discussion to see how people handle the diuretics. At what point do you use diuretics? You don't use diuretics. और उसको किस तरह से fit करते हैं different scenarios में. Maybe I think let's have other. I would ask everybody else कि वो क्या करते हैं.
जी सर, डॉक्टर बैस.
Yes.
हाँ, आपने भी कहा कि after that of the filling compartment in the hypotension, you will, if one will give the lot of fluids, and you will not give that of the Lasix, but the probably in that of the oliguric state, all the efforts are made to make that of the non-oliguric renal failure as compared to oliguric. So attempts are made to pass the urine as compared to oliguria. So what do you comment that you will not advise diuretic?
Go 800, 900, 1000. Okay, thank you.
Thank you, Ji, Doctor.
Yes, yes. That actually, again, some time ago, people used to say that a patient is, non-oliguric patient is better than oliguric acute kidney injury. But I don't think there any evidence support that. Just because you.
Sorry to interrupt you. In your opinion, that the prognosis of the non-oliguric renal failure with the oliguric renal failure are the same in management of that of the.
I don't think that you need to give patient otherwise does not need diuretics, because patient respiratory, his lungs are clear. Patient doesn't have very obvious volume edema. In that case, you don't need to give. Actually, I would avoid Lasix at that time. Even patient has no urine output, I would not give any diuretics just to make urine. Some people say, okay, let's jumpstart that. Some people say, we need to see urine. I mean, I got all the time. If patient is not making urine, there's a sign that patient has acute kidney injury. I will not give him Lasix just to see the urine output. There's no studies shown that making oliguric patient non-oliguric make any difference outcome-wise.
Okay.
Yeah, I think this is what I meant कि historically ये भी इस चीज का भी जो concept है वो evolve किया over the years. पहले ये concept होता था non-oliguric का. फिर आपको याद होगा KDIGO ने एक guidelines में diuretics के काफी against पे लिखा. लेकिन I think फिर जो बात यही है कि अगर volume status जो है ना वो एक बड़ा determining factor है. But I think this is an important concept जिस पे हम, मेरा ख्याल है jury is still out there. I don't think we have clear directions or guidelines on that. और जो experience है वो भी काफी variable है, क्योंकि आप community में मैंने देखा है लोग अभी भी काफी different किस्म के इसके responses हैं. तो इसलिए मैंने कहा कि maybe we can ask कि भाई what is the experience of people in the call today, कि at what point they like to use diuretics. जैसे Dr. Medina ने बड़ा clearly बताया. I think we should ask other people as well as what they do.
Let me make one point again. It's a very important question with Dr. Akhund. We still question each other. Last time when I to ASN meeting, one day before the main meeting, there was a meeting which always happened, that critical care nephrologist meeting. in that case also, it was like a unanimous opinion. There's no like two opinion about that there's no reason now going for the last decade or so, there's no reason to convert patient from oliguric to non-oligurics, and it does not improve prognosis. So actually can do more harm than benefit on that patient.
सर यही क्वेश्चन मैं पूछना चाह रहा था कि अगर आप लैसिक्स दे देते हैं तो इट विल वर्सन द इंजरी ऑफ द किडनी.
First of all, there's no benefit, and then you can worsen that you possibly can. Okay, patients need some volume that which is okay, and that you can make patients. Actually, if you go totally, there's also called like a furosemide stress test. Okay, that's another thing. But sometimes you give patient not to make patient urine more, just to see the response. There is a like a called furosemide stress test. If your patient is not making urine, patient has ATN. If you give like a 80 milligram of Lasix IV and patient does make urine because of their Lasix, it means that prognosis wise probably is a bit better. You can see that tubules are still functioning to some extent. But again, just to make urine output more when patient is not volume overload symptomatically, they actually can make harm than benefit.
So
I think the harm came from the outcome, and I will ask Dr. Agha to comment on this question too.
So there's a couple of things that I think we need to tease out a little bit better. Peri-GC AKI, I think we're talking about septic shock here, ischemic ATN. So I would keep all other causes kind of on the periphery at this time, because this is the commonest scenario in which is किस्म की हम situation को deal करते हैं. So we need to kind of narrow this down. And so what we need to do is understand the pathophysiology of what is happening and what is it that we are trying to do. So we all agree, I think, that we stipulate that pre-renal azotemia is a situation in which the renal parenchyma is intact, and ATN develops when the renal parenchyma is no longer intact due to whatever reason, but we assume that it is because of ischemic damage itna severe tha ke the tubules are no longer intact. Now, the intactness of the tubules ranges from a very early state where the epithelial cells have reversed their polarity. So epithelial cells, as we all know on this call, have a very strong barrier, and what's happening on the tubular side is kept very different from what's going to happen on the interstitial side and the blood side. And so there's peptides at the dense filaments called RGD peptides, and you lose that anchor. And once that happens, the ions start going both ways. And that is one of the first things that happen when ischemic ATN, when pre-renal azotemia is marching towards ischemic ATN. And then obviously the cells die, they slough off, and there's full-blown ATN, which becomes oliguric. So the idea behind all of what we are trying to do is to reverse some of these injuries and prevent some of these injuries. So jo fluid resuscitation ka concept, and that is to increase renal perfusion. And if we are able to do that in an effective way, we'll restore urine flow, which is our sign that, oh yes, things are better now. But if we have moved from a stage jahan pe the tubules are no longer intact, then giving them Lasix at that time is not going to change the course of the disease. The tubular cells will need to heal themselves. Way back when, in the 1980s, when Dr. Vass and I were in medical school, there was this concept that when you give loop diuretics, the thick ascending loop of Henle has this very energy intensive pump, the sodium potassium 2-chloride pump, which is inhibited by the loop diuretic. So maybe there's a role in loop diuretics attenuating renal injury. That obviously has been proven not to be the case. As Dr. Abbas mentioned, there is this entity called furosemide stress test, which is just trying to stratify how severe the tubular injury is. And I don't know how much that matters in the bigger scheme of things. But if you give somebody diuretics when they are becoming oliguric, it should not be to look at urine in the Foley catheter. The reason you want to give somebody diuretics is because they're in volume overload. So the downside, I think Dr. Kesser asked that what is the downside? The downside is you may actually intravascularly deplete them further, and that may actually perpetuate the tubular injury. So you may make some urine, but you'll drop their intravascular effective perfusion. So the magic concept here is of effective intra-arterial perfusion pressure. And that's what Umar was saying, that you go to some of these ICUs where people are in, you know, they're third space like crazy, they are 25 liters ahead. But if you put a central line or a PA catheter in them, their intravascular volume will still be down. And sometimes the correct treatment still is to give them volume. But diuretics should not be directed by the urge to see urine. Diuretics should be directed based on a clinical indication, which is volume overload. Just giving them diuretics and converting them into somebody who's got a non-oliguric state is not going to change their 30-day renal or clinical outcomes. So you treat the renal failure on its merit and use the diuretic on its merit. That's kind of how I look at the problem.
No, thank you. I think this is very comprehensive and very, thank you for connecting those dots. So really the concept was in the end, as Dr. Aga mentioned, about the outcomes, because you don't change the outcome in the end. Yes, you may see that 6 hours or 8 hours, you may see more Foley, but you don't change the bigger outcome. So volume status is probably the biggest driver in this situation to determine the use of diuretics. And I have changed my practice, when I was in fellowships, 10 years ago, we used to use at our hospital this conversion of oliguric to non-oliguric, oliguric to non-oliguric a lot, but I think we have changed that practice. The decision to add Bumix drip or Lasix drip or any diuretics is based on the volume status. And that's where I think our role is, like, we have to do this assessment for the patient. And a lot of time, they rely upon nephrologists to help the teams to do that.
And I would also add that ये जो नई sepsis की protocols हैं, the fluid boluses and all that, so हमारा काम थोड़ा आसान हो गया. Everybody is overloaded by the time we are called in to see the patient. So you end up giving them diuretics anyway. So.
सर हमारे यहाँ जो पेशेंट के अटेंडेंट है ना, दे वांट टू सी यूरिन कि भाई गुर्दे चल पे ने, दैट इज द रीजन कि वो हम लोग फिर उस हिसाब से कहते हैं कि यार थोड़ा पेशाब आ जाए, कोई इज्जत रह जाए, नेफ्रोलॉजिस्ट आया सी, ही डिड समथिंग.
Abbas, Dr. Abbas, sorry, one question from my side. Frequently we see the patient of hypotension, the cardiogenic, the sepsis. They are they are also having a hypoalbuminemia, with the albumin in the lower side, with the low albumin. So what is the role of that of albumin in management of that of the hypovolemic shock or hypertension?
Okay, so let me make it very clear. Actually, this is a topic again. I mean, it's going on. It's like one of the many reasons because we fight with the surgeon. Okay. I mean, they like to give albumin on every patient. I mean, they think that albumin is, but if you are an ICU doctor, you don't like to. Basically, to make it simple, there has been many studies been done over the last decade or so that what is the role of albumin in different scenarios. The only scenario which showed that is beneficial, and there's no controversy about that, is a patient who are a cirrhotic patient and who are risk for hepatorenal syndrome. Those patients definitely need albumin, no question about that. Other than that, septic shock patient, albumin is low because of chronic infection, inflammation. There is no role of giving albumin. A patient with albumin less than 1, sometimes you see giving that patient albumin is not. Sometimes they say, okay, let's give the albumin because third spacing, right? You have to give Lasix,
yes.
Right? That's a very common scenario, third spacing. Even that concept has been gone out of the way. There's no such thing. Every situation where there is third spacing, albumin can also go through that space. So a patient has third spacing, and you give albumin, patient has capillary leak, that albumin will not stay intravascularly. It go to the interstitium, and from there it can cause increase on cardiac pressure and going to pull up more fluid into the interstitium. So again, sometime, very rarely, I have used 3% or 5% saline for temporarily to decrease edema, which we normally don't use, but that thing works better than albumin. But I don't think that in Pakistan or anywhere else, we use that 3 hypertonic saline solution to pull off in condition where there's patient third spacing. But albumin has no role in that.
इसमें मतीन एक पॉइंट और भी है कि जो एल्ब्यूमिन है दैट इज एन एक्यूट फेज रिएक्टेंट whenever you have a sepsis and inflammation infection your albumin will immediately go down तो उसका ये मतलब नहीं कि उसकी albumin लो गई है that's a acute phase reactant वो आपको नजर इस तरह आ रहा है तो जिस तरह डॉक्टर अवैस ने पॉइंट आउट किया कि albumin now has a very limited role subgroup analysis of albumin study which was done in a septic shock setting does have a small minor role, but I don't think in a resource limited country, albumin really has any role. Thank you.
Okay, thank you.
Okay, so I think if we summarize our talk, like again, vasopressor, and septic shock, or even cardiogenic shock, the first medication to be used should be norepinephrine. And second, if norepinephrine is not enough, you need to add pressor. That should be, in most of the scenario, should be vasopressin. And still not enough, then you go to replace norepinephrine with epinephrine or add epinephrine. And in a situation where you are worried about patient has arrhythmias or patient has very severe tachycardia, not like a regular tachycardia, which is actually reaction to sepsis like 130 sinus tach. If really have bad tachycardia, AFib, rapid AFib, you don't want to use any agent with the positive chronotropic effect, then you can use only vasopressin, or you can add neosynephrine or phenylephrine in that case. So again, dopamine should be kept away. In pretty much all these scenarios, we see hypotension, except where patient has bradycardia. And also and also when you need inotropes, milrinone is the better drug than dopamine, but make sure that you keep an eye on that patient's renal function and the dose need to be adjusted accordingly. Okay. And albumin use, unnecessary use, it should be discouraged. We use here also, most of the time use unnecessarily. But there's just a wastage of money and there's of no use unless patient has cirrhotic patient who are you trying to prevent from hepatorenal or treating hepatorenal syndrome. That's the definitely indication for. Another indication for patient albumin in cirrhotic patient is when treating hyponatremia. Basically, this is that one of the treatment for hyponatremia in patient who has cirrhosis is albumin, because albumin decreases their ADH secretion, and that can improve their hyponatremia in patient with cirrhosis.
Yeah, another point that people who are covering the burns unit anywhere, after the initial resuscitation in the burn on the first day, then the next day you can try albumin in this subgroup of population, only in places who are covering the burn units.
Okay. I'll be glad to, talk about any other question, any other things we need to talk about in this particular topic. Are we okay?
Okay.
Yeah, another important point, Dr. Awais, that before starting any patient on vasopressin, because they're already on some reasonably higher doses of levofed, you have to take the history in Pakistan regarding any history of mesenteric ischemia, any peripheral ischemia, any history of coronary artery disease, any ongoing active coronary ischemia. So these things should also be kept in mind.
You're right, but again, the thing is that what are you going to do if patient has this history?
Because then the vasopressin, then maybe with the norepinephrine, the next choice will be an epinephrine in that scenario, rather than vasopressin.
Epinephrine actually cause more mesenteric ischemia than norepinephrine actually. So in our practice, I mean, also the studies also shown. So in that case, you have very limited choice, because if you don't decrease the improve the pressure, blood pressure, it will also decrease the ischemia. But again, you are absolutely right. That's always a concern. Patients are prone to develop, mesenteric ischemia, because that actually a death sentence. Once patient develop further down, I mean, they cause septic shock, and patient can go to the next level of shock. So obviously you like to give more fluid and make sure your patient is enough fluid, and you try to minimize their dose of vasopressor. But all vasopressor practically, they cause vasoconstriction, and that can increase the risk for. But again, cardiac output help that, increase cardiac output in that case.
Because sometimes this mesenteric ischemia may not be occlusive. That will be the non-occlusive type of mesenteric ischemia, which is usually associated with hypoperfusion.
That's right. So quickly, last question, maybe what kind of fluid we use if we need to use in, I mean, it's normal saline, or you want to use Ringer's lactate?
Normal saline.
We are using balanced solutions. Ringer lactate is usually our go-to.
I mean, the short answer is yes. I mean, you can discuss what is the pros and cons, but again, short answer is yes. I mean, the Ringer's lactate, more and more small studies, some big studies also showing that that's beneficial. Actually, one of the different, when I look at for a study or actually a talk, the renal perfusion effect of different agent. One of the things which decrease renal perfusion is chloride. Chloride actually cause afferent vasoconstriction. So if you give normal saline, have more chloride in that, that theoretically and maybe practically also can decrease renal perfusion. So balanced solution, Ringer's lactate is a better choice. But again, the study shown difference is not that much that you have to have it, but maybe slight benefit you get, particularly patient in ICU.
Sir, इसके ऊपर तो मेरा ख्याल है कि we will need to have another whole discussion. I think
it's not that simple. You're right.
आपने थोड़ा सा बता दिया. It's very good. So just a brief. So then I'll probably let you everyone go because 11:30 हो रहे हैं इधर. So एक question होता है जो actually Dr. इरफान आगा ने हमें scenario एक actually put forward किया था, which is very very common here. And the scenario is कि जी patient के पास हम जाते हैं, उसमें सारा कुछ ही लगता है third space हुआ हुआ है. अब उसको CVP देखते हैं, CVP 6 होती है. And essentially, if you look on the whole, so the patient is overloaded, but actually he's in a positive balance. So in that scenario, sir ने Dr. इरफान आगा ने थोड़ा सा कहा कि maybe शायद उस patient को fluid देने की जरूरत है. तो am I right in saying कि जी fluid ही देने की जरूरत है, because patient तो actually volume overloaded है. उस time पे usual practice यही होती है कि हम उसको IV Lasix दे रहे होते हैं. और डर यही होता है कि इंट्रावास्कुलरली वो वॉल्यूम डिप्लीटेड है, सारा फ्लूइड पड़ा एक्स्ट्रावास्कुलर है. व्हाट वुड यू से इन दैट सिचुएशन? और आमतौर पे उस जगह पे आईसीयू वालों से लड़ाई हो रही होती है कि उधर एल्ब्यूमिन चल रही होती है और हम कह रहे होते हैं इसका फायदा कोई नहीं है. So what do you have to say about that, sir?
I mean, anybody has comment before I give my comment? I actually, because I have fight, you're right, every single day, so I want to myself back up with all the knowledge. So when I fight to that other people, I should tell them that, okay, this is the evidence-based, thing I'm saying to you. Basically, in that situation, when patient has obvious edema, patient has, whatever reason, congestive heart failure with low EF or cirrhotic patient, in that case, doesn't matter what CVP is. CVP is not the best indicator of volume status. In that case, you have to give diuretics in that case. Depends on the patient condition. Particularly, let me talk about cirrhotic patients. Cirrhotic patient, there are two types of cirrhotic patient. One have ascites without edema, and the other have edema and ascites both. So those patients who have ascites, no edema, is something with ankle edema nahi hota. Those patients are even very, very difficult. If you give a little bit more Lasix than they should be, they will lead to increased creatinine or lead to hepatorenal syndrome. So those patients give very low dose of Lasix because the fluid has to be mobilized from interstitium to intravascular. You have to deplete the intravascular volume by giving Lasix, and then fluid will mobilize from interstitium to intravascular. But if you are too aggressive and you want to empty the intravascular volume too quickly, that can lead to ischemia of the organs, kidneys or even heart. So then have to be extra careful. Compared to those patients who have ascites and edema also, those patients you can be a little more aggressive. Those patients has a little more easy mobilizing the fluid from interstitium to intravascularly. You can be given higher dose of Lasix, those patients. But again, generally, like patients who have a CHF or low cardiac index, the patient has third spacing because of hypoalbuminemia. On those patients, you have to give diuretics unless patient is again patient is hypotensive, and in that case you cannot rely just on CVP. Other measurement also, like patient is hypovolemic. Obviously, if you give hypovolemic patient diuretics, you will cause damage to ischemia to the organs. But blood pressure is okay, but CVP showing not very high, and patient has edema, those patients need diuretics.
So, Dr. Rez, this is very interesting. So, let's separate out cirrhotics, because cirrhotics is a special case. I mean, cirrhotics, like you mentioned, in a situation like that, what I would do for a cirrhotic is to give them albumin and diuretics, right? Because that's the only time when you do that. We deal with a large liver transplant program, so large cirrhotic population, and we run into this all the time. So let's not talk about cirrhotics. Let's not talk about the congestive heart failure patients, because for congestive heart failure patients, by definition, most of the time their intravascular volume is up. That's what congestion is. So I think the question to ask is in the septic shock category. And so how do you approach somebody who came in with septic shock, is hypotensive, is edematous, is oliguric, and let's, for the sake of argument, throw in a PA catheter, and their veg is low, PA pressures are low, and CVP is low. How would you manage that patient?
I mean, definitely, I agree with you. Those are not the easiest patient, and patient is hypotensive. That's the hypotension is the key. Patient is hypotensive. In that patient, if you're giving diuretics, you're looking for trouble. But again, patient is some patients are chronically hypotensive. Cirrhotic patients are commonly chronically hypertensive. Their systolic blood pressure is 90 all the time, and those patients need vasoconstriction, PO, midodrine commonly given to them on chronic basis. So a patient is cirrhotic patient, as you mentioned, and those patient has obviously has low albumin. Otherwise, again, not just CVP. If you have overall your judgment is that patient his volume depleted, obviously I will not give diuretics of those patients. I would give volume. As you said, cirrhotic patient can do good on albumin. That's the only situation where albumin is justified to be given.
So the way I look at it is the difference that comes into this, and sometimes the ambivalence that comes into this, is to assessing volume in a 2-compartment versus a 3-compartment model. We joke sometimes that SCUF stands for surgeons cannot understand fluids, and that is they actually think of volume in terms of a 1-compartment model. They think of a human being as an amoeba, and if the amoeba is swollen, there must be more volume. But as nephrologists, we look at effective perfusion pressure, that what is actually inside the blood vessel, which is leading to GFR or lack thereof. So I have sometimes, when I see patients like this who are hypotensive, where intravascular volume based on my assessment is low, and who are oliguric, I sometimes give them fluid for a short period of time to intravascularly stabilize them. And then what you do is exactly what you said. That is exactly right, that you start mobilizing fluid from the 3rd spaced compartment into the blood vessels, and from the blood vessels into the tubules, so that you're moving fluid through. And you have to find what is the right rhythm to do that, because if you try to do it too fast, you're going to dry them out intravascularly, and their kidney numbers are going to look worse, and you're going to start getting worried that they're moving in the wrong direction. So you have to move them so that the 3rd spacing doesn't lag behind the diuresis that you're achieving. And I think that is where there's this art of medicine, and we can't be changed by AI yet.
I think we should definitely, I agree with you, your approach. We should talk some separate thing because this intra-abdominal pressure, intra-abdominal hypertension, compartment syndrome, then this cirrhotic patient, that's a very big topic and needs a good discussion. I just had like an hour ago, like a really hard argument with that surgeon. A patient has a abdominal compartment syndrome and he didn't want to, decompress that, keep giving more fluid. So this is an area where we see a lot of patients now and then actually mismanaged. So we should talk about that in near future also.
Dr. Vass, we should also talk about the antibiotics should be given in AKI with septic shock.
Antibiotic definitely. There is that any patient who are you suspecting any kind of infection and sepsis. Antibiotics should be started within an hour in ER, not than in ICU. So after that, you can cut down antibiotic if there's no cause of infection found, or we cut down the deaccelerate the antibiotics. But definitely, if patient has sepsis, you have to start antibiotics right away.
No, the choice of antibiotics should be discussed in some day.
Yeah, definitely. Obviously.
Yes, just one point, Dr. Vass, I want to highlight also that what Dr. Irfan has suggested, the effective arterial blood volume has to be emphasized again and again to everything. Even when we get this nephrotic patients and they are over diuresis and they come with dizziness, all this, because they have edema peripherally and the fluid is in the third compartment and intravascularly they are volume depleted. The other point I want to emphasize is that the CVP is a single static CVP is the most useless thing to rely upon. You can have a high CVP and you can still be fluid responsive, and you can have a very, very low CVP and you can still be fluid unresponsive, because it absolutely does not tell you where part of the Frank-Starling curve it is. So that has to be also kept in mind regarding our practice in ICU and regarding the resuscitation of these patients.
So two themes are very coming obvious. One is the what type of patient population you are trying to assess the volume status upon. As I described, the patient population compartmentalized by whether they are in heart and vascular ICU, surgical ICU, or medical ICU. I think that the issue is really, what patient population you are dealing with. I think all of us who are in busy liver transplant programs, I think we see, and Pakistan too, I think we see over a very high share of hepatorenal syndromes, and some folks who are in the very busy cardiac centers, so they see the complex congestive heart failure, and I think septic shock is always there. So really, what's the patient population? And the second theme, I think what I learned today is the timing of your evaluation for that patient. If you're seeing patient on day number 1.5 versus day number 3, I think your management for that particular patient population changes. So that's where I think the art of the medicine and understanding, where on this patient's journey you are capturing that patient on that particular day. Because most situations, I think once we have been doing this for a while, 70 to 80% situations, I think we get a pretty good gut feeling by seeing the patient, looking at the chart, putting the hand on the patient as where the patient is. It's really the 20 to 30% patient, and maybe 10 to 20% patient when there is this doubt as this patient is dry or wet. So I'm sure like everybody has their own method of doing some sort of a test or some sort of a trick and tip to get them through. But really, you have, what I do is I tell my residents is, okay, take a decision, take a step, do the intervention, move the clock forward 6 hours later, 12 hours later, and reassess. And I think then it's really the day one evaluation and 12 hours later evaluation that will give us, more better picture. I wouldn't say comprehensive. So those are some of the nuances I think we all live with every single day, and or some of the fights we fight with other people. It's very difficult for them to understand what we are saying. So instead of trying to make them to convince them, I just kind of I say, okay, let's do something. Move the clock forward 6 hours later. Put some guardrails. Reassess the patient. So this has been my approach.
Okay.
That's pragmatic. There's actually papers looking at this. Early nephrology consultations actually change the arc of AKI. So, that's the message. If you get in touch with the patient earlier, the outcomes are better.
Okay, so I think it's 1 hour and 30 minutes already. So please continue if you have any question, or let's keep this discussion open on the forum. And if you have question regarding this, please put on the forum and we'll try to answer that, or we'll try to discuss that. So any other question before we say good night to everybody?
On behalf of everybody attending, may I thank Dr. Abbas and Colonel Farouk for very good presentations and for making this discussion possible. I learned a lot. Thank you very much, guys.
Okay, thank you everybody. Thank you very much, and we'll be talking to you soon. Okay, for Pakistan, good night.
Thank you. Bye bye.